Good morning. I am Dr. Surender, Professor of Anesthesia, Allareddy Medical College for Women. Today I will be discussing with you about perioperative fluid therapy. Perioperative fluid therapy is two types. One is replacement of normal losses because of the fasting pre-existing fluid deficits. Second is replacement of losses from the surgical wound. Fluid deficit usually arises because of the fasting period, no oral intake is taken. If the prolonged preoperative fasting is there, then there will be more deficit will be there in that patient. Intraoperative blood and fluid loss, operative losses from the tissue site. Then exposure of intestines and other organs to large surface area because of the big incisions. Dry gases, when you intubate and ventilate the patient also, there will be fluid deficit can arise. And the fluid replacement depends on the individual basis. For example, children, the calculations we use is different. Adults, the calculations we use is different. Type of patient, whether it is elective case or emergency case. Emergency case will have a preoperatively itself he might have a deficit because of intestinal obstruction or perforation. He may have additional losses because of this. Similar, whereas elective cases only because of the fasting state losses. Type of surgery the patient is going to do. Endoscopic surgery, not much of operative losses from the surgical wound site, whereas in open surgery is a lot of amount of trauma. And then that is surgeries are divided into three types: mild trauma, moderate trauma, and severe trauma. Depending on the site and size of surgical incisions, we divide them into different groups and the calculations will differ. And positioning of the patient is also important in these patients. Choice, there are crystalloids, colloids, and blood products. These are the things which we replace usually in the postoperative. Before we go into preoperative fluid therapy, we should understand what are the fluid compartments in the body. Body is not a tank where you put the water, everything will go into the particular segment. It will be divided into different. Each fluid will, how it behaves is different. So we have to know the type of fluid, how their distribution will come. And what are the crystalloids and colloids, what are the advantages, disadvantages. And perioperative fluid therapy without any disturbed fluid balance and disturbed fluid balance. That is, elective surgery is no preoperative deficit is there, disturbed balance is not there. Whereas a perforation, intestinal obstruction, there is a disturbed fluid balance. What type of monitoring we have to do? Fluid therapy in children and pregnancy makes a difference. Then simultaneously, calculations are different. Electrolyte imbalance we have to correct. Water is divided into different compartments. Interstitial, part of the fluid is present in the form of a plasma in the intravascular. In between the cells, outside the cells, also there is some amount of fluid is there, that is interstitial fluid compartment. Major portion of the fluid is there in the intracellular. 2/3 of the fluid, the body, a male patient have 60% of body weight in the water. Out of that, two-thirds is in the intracellular space, and one-third is in the extracellular space. Out of that, 5% is in the plasma. Remaining things is interstitial, in between the cells. The composition of each one is different. Plasma and interstitial fluid, main component is sodium, whereas intracellular potassium is the main component. And volume, two-thirds, that is 60 kg patient will have a 42 liters. Out of that, 28 liters intracellularly, remaining 14 liters will be extracellular. The volume is different, compartment sizes are different, composition is different, but one thing is common between all compartments, that is the osmolality. Osmolality of this one is around 290 millimoles. 285 to 300 usually osmolality. And in between the plasma and the interstitial fluid compartment, there is a barrier. This is known as the endothelial barrier. This endothelial barrier will allow small particles to seepage into the interstitial fluid, can move out of the intravascular compartment into interstitial fluid compartment. Then between the interstitial and in the cell, there is a barrier, this is known as a cell membrane. This cell membrane has got a positive and negative charges. When a fluid like sodium chloride is given to the patient, if sodium and water can freely move in depending on the osmolality gradient is there, water can move. Then, whereas electrolytes will not be permitted to move in. Positive charge, sodium comes near the positive charge on the cell membrane, it will be repelled. It comes near the negative charge, it will be attracted and holds it. So, charged particles cannot move. Non-ionized particles can easily move from interstitial fluid compartment to intracellular compartment. There are different types of fluids available to us. The first we will consider 5% dextrose given to the patient. 5% dextrose, when it is given to the patient, goes into the intravascular compartment. Being a crystallite, it crosses the endothelial barrier, enters into the interstitial fluid compartment. Then this 5% dextrose is hypoosmolar solution. Normal osmolality is 290, it is 253, it is less than that. So as a result of that, more water is there than the solute content. Then these solutes can enter into the intracellularly. So it distributes in all the compartments. Throughout 42 liters it distributes. Hardly any fluid remains in the intravascular compartment. So it is a poor fluid to be given when patient is in shock. It contains 5%. 5% means 5 grams per 100 ml. Each gram will give 4 calories. So 500 ml will give 25 into 4, 100 calories. So nevertheless, this gives some calories which may not meet the entire calorie requirement but prevents the ketosis. So mainly 5% dextrose is given as a water replacement, and also some calories it will get. Then this water replacement may be needed in hypernatremia cases, where there is a deficit of water in there. Then you have to replace. Best way to replace is to give 5% dextrose to the patient. Similarly, in the body, there are some losses will occur in the form of from skin and subcutaneous tissue. During the summer, sweating, insensible losses from the respiratory tract, that will result in fluid losses which are hypotonic, means more water, less sodium is lost. So it is replaced with 5% dextrose with 0.45% saline. Disadvantages of 5% dextrose is if you give too large volume, since it is hypotonic, the water accumulation will occur, that dilutes the sodium, so dilutional hyponatremia and water intoxication can occur. Next fluid is Ringer's lactate. Ringer's lactate is given into this. Since it is a crystallite, it crosses the interstitial endothelial barrier, enters into the interstitial fluid compartment. Then, since it is an electrolyte solution, it cannot cross the cellular barrier to enter into the intestine. It is basically distributed between the plasma and interstitial fluid compartments only. So 1/3 will remain in the intravascular compartment, 2/3 will go into interstitial space. So it is a better agent to replace blood loss than 5% dextrose. Since it is a hypotonic, small amount of excess water which is there can easily cross the cellular cell membrane and enter into the intracellular inside the cells. As a result of that one, cells will swell. So this is especially in neurosurgery cases, head injury cases, this can be problematic. 5% dextrose we cannot give. Ringer's lactate also is a problematic. So we try to replace normal saline in those cases. Where do you use Ringer lactate? Its composition is same as blood. 140 milliequivalents of sodium, 108 milliequivalents of chloride, bicarbonate 27 milliequivalents, and potassium 4 milliequivalents. So its composition same as plasma. So it can be used whenever there is a losses from the blood loss or interstitial fluid losses such as burns, etc. So this is the fluid of choice. Then replaceable blood loss which is not very considerable amount, then can be replaced with only crystalloid. The best crystalloid available to us is the Ringer lactate to replace it. Lower bowel obstructions. Ringer lactate is the choice. Where the sodium is lost, potassium is lost, along with that one, bicarbonate is also lost. So that is replaced with the Ringer lactate. It is contraindicated in renal failure cases with already hyperkalemia is there. Then patients with neurosurgical cases, head injury cases, we cannot use. The lactate which is present in Ringer lactate is metabolized in the liver and bicarbonate is generated aerobically. When aerobic metabolism is depressed in shock states, this conversion cannot occur. Similarly, if the liver is diseased, this conversion cannot happen. So in liver diseases, this lactate conversion will not occur. Then lactate will accumulate, lactic acidosis will arise. So it should not be given in those conditions. Similarly, neonates where liver is very immature, ringer lactate cannot be given. So there are other solutions like acetate solutions or Ringer's acetate solution is which can be given to the patient. Sodium chloride is also behaves in the same way, but it is isotonic. So it doesn't cause a cellular edema. So sodium chloride is the choice for neurosurgical patients, renal failure cases, and also it is a choice in patients with blood loss also. If renal lactate is not available, then we can use upper GI obstructions. Like normal saline is the fluid of choice. There is a loss of sodium, chloride, potassium, and hydrogen. So sodium chloride is an acidic solution. It replaces the hydrogen. So there is a special fluid is available, isolate G, which is a gastric replacement fluid. In case of isolate G is not available, sodium chloride you can give, and you can also replace the potassium, little potassium added to it, around 10 millimoles of potassium per liter, then it will replace the gastric juice. Then colloids. Colloids are large particles which cannot cross the endothelial barrier, remain in the intravascular compartment, thereby maintain intravascular walking. Classic example of colloid is blood. There are some other type of colloids are available which will remain in the intravascular compartment, and because they are hypertonicity, they draw the blood from the interstitial fluid into the intravascular compartment, thereby intravascular volume will be expanded. So they are known as a plasma expanders. So various intravenous fluids available to us is 5% dextrose, normal saline, dextrose saline, Ringer's lactate, Ringer's acetate, isolate M, P, E, G, R, etc. As we already discussed, 5% dextrose gives some calories, but entire and caloric requirements cannot be given. There are no electrolytes as available. It is mainly used as a fluid replacement, water replacement cases, in case of insensible losses from the skin and respiratory tract, as well as for patients with hypernatremia cases. Too large volume if you give, it will cause water intoxication or dilutional hyponatremia. Sodium chloride, sodium gives 154 milliequivalents, little higher than the plasma. Chloride content is very high. Too large volume of sodium chloride if you give, hyperchloremic acidosis will occur. Upper GI losses, where there is a loss of gastric juice is there, which contains sodium, potassium, chloride, and hydrogen. So these are the things which is lost. It will replace the sodium, it will replace the chloride, it will replace the hydrogen ion also because it is acidic solution. It will correct the metabolic alkalosis associated with the vomiting. It is the best solution available to us provided you can add little potassium to it. Too large volume if you give, it will cause hyperchloremic acidosis. Cardiac patients, in patients with hypertension, you have to be little guarded, sodium overload. Dextrosaline. Dextrosaline has got all the advantages and disadvantages. Dextrose and normal saline put together. Then half-strength saline, that is dextrose with 0.4% saline, is the fluid of choice for insensible losses from the skin and the sweating. Fingers lactate, composition same as plasma. Only thing is lactate has to be metabolized in the body. Since it is hypotonic, it cannot be used in head injuries, patients with neurosurgery, after neurosurgery patients, post-operatively or intraoperatively cannot use this. Then osmolality is 0.273, slightly more excess water compared to solute. This excess water will cause cerebral edema. It is contraindicated in renal failure with hyperkalemia. It cannot be given. Children, it cannot be given because of lactate. Children cannot metabolize lactate to bicarbonate. Liver is immature neonates especially. Then liver failures, you cannot use. There is one more solution, acetate ring. Unlike lactate, acetate can be converted in not only in the liver but also in the extrahepatic tissues such as kidney, muscle, etc. Anaerobically also it can be converted. So this is the acetate ringer is the choice whenever the patient has got it. You have to give a replacement in children. So there is one special solution is available in children known as isolate P, which contains this. This is the adult maintenance fluid. This is low sodium, low chloride, but it contains potassium, high potassium content along with lactate. Isolate P is a pediatric maintenance fluid, low sodium, low chloride, and it contains acetate, which can be converted into bicarbonate extrahepatically. Isolate E is the extracellular replacement fluid, which is commonly used for lower bowel obstructions. This contains potassium little higher than the ringer lactate. Isolate G is the gastric replacement fluid. It contains sodium, chloride, potassium, and ammonium chloride. So this ammonia gives hydrogen and corrects the metabolic alkalosis associated with the vomiting. Isolate R is another type of adult maintenance fluid. Plasma light solution. This has got osmolality same as blood, pH same as blood, then its composition same as blood. So this is the ideal solution to be given in replacement fluids. Acetate contains acetate which can be converted into bicarbonate, but it doesn't have a calcium. No calcium is there in this. These are the various fluids and their compositions, their osmolarities. You can see very easily 5% dextrose and lactate are hypoosmolar, remaining on density is same as plasma or a little higher. One colloid which we have got is 5% aluminum, which is 3% cyanide also. Hemaxil, gelatin preparations like hemaxil and gel fusing, then dextrons, pita starch and PET starches, and albumin. So these are all the colloids which are made. Hemaxil is urea linked with gelatin. Its molecular weight is 35,000, so it can be filtered by the kidney. Kidney can filter up to 69,000 molecular weight. Allergic, it is made from the animal protein, so allergic reactions are common. Crossing, matching and typing should be done before giving the gelatin preparation. It persists in the body for 4 to 6 hours and raises the intravascular volume by 100%. Gel fusing is another gelatin preparation which is made synthetically, and its lasts for 3 to 4 hours. Its molecular weight is same as hemaxil, 100% expansion. Hemaxil contains calcium, 6.25, whereas gel fusion contains very less calcium, and hemaxil also contains the potassium 5.1, so you cannot use hemaxil in renal cases, renal insufficiency, whereas the gel fusion can be freely given because of the low potassium content. Gel fusion, since it is not made from the animal, it is from the plant. Synthetically, anaphylactic reactions are less common. So one has to face which proved to be gelatin, fetal, we have to use gel fusion may be better agent. Then we have got a dextrons, which are intermediate products between the monosaccharides and the polysaccharides. D40 is a low molecular weight dextron, which is 40,000. Then 70,000 and 150,000. There are this 40,000 is used, has got a property of coating the vessel wall with the negative charge, RBCs and platelets with a negative charge. Thereby, platelet aggregation which occurs during the shock states, it prevents, thereby microcirculation is likely to improve. Similarly, patient with stroke due to thrombotic strokes, this is a good solution for low molecular weight dextron. Action process for 6 hours, 70,000 for 12 hours, 150,000 for 24 hours. We don't want a colloid with long duration of effect. So usually we don't prefer this. Usually we use only dextron 40,000. This interferes with the plotting and grouping. So we have to take a sample. Then anaphylactic reactions are there, although they may not be done from about 450,000 molecular weight. Points dextron, when starch is introduced into the body, causes good plasma expansion, but within minutes its effect goes. In order to prolong the starch effect, this hexaethyl molecule is added to the starch. 70% replacement you do in this one, it will become 0.7. 50%, but its action lasts for a longer period. We don't want that much of action. So it is made from the maize. So it is a plant source. Anaphylactic reactions are less common. This is a 200,000 molecular weight, 0.5 replacement. That is 50% replacement. Tetrastarch is 130,000 molecular weight and 40% of chain carbon atoms replaced with hydroxy. So this is, the concept is to go for lower and lower molecular weight and lower and lower hydroxyethyl replacement. So no pentastarches and tetrastarches are available for us to use in the intraoperative period and postoperative period whenever blood is not available. Remember that every colloid has got a problem of So you have to give only in if really it is indicated. There are reports of renal failure occurring with this starch. So you have to be guarded. The crystalloids not only they replace intravascular deficits, but also it will cause interstitial deficits also it will replace. If you want to give blood replacement, you have to give 3 times more. Allergic reactions are not there, they are inexpensive and freely available. Whereas colloids are larger molecules, they remain in the intravascular. Good expansion will occur 1:1 ratio. When allergic reactions are common, then they are exposed. They are expensive. So crystalloids easy to administer, no risk of adverse reactions, no disturbances in it causes good diuresis, inexpensive, but it is a poor plasma volume support. Large quantities are needed, hypothermia, it reduces oncotic pressure, risk of edema. Then similarly, colloids, moderate volume can raise this one, minimal risk of tissue edema, but anaphylactic reactions expensive. Intraoperative fluid therapy replacement in surgical patient preoperatively, they require 2 ml per kg of body weight, 5% dextrose, 0.4% saline. Then replacement fluids during the operation because of the blood and the evaporative losses from the tissues replaced with ringer lactate and plasma. Special type of fluid replacements will be done in case of certain diseases like patients with DU perforation. Preoperative fluids amount you have to decide type of fluid. Type of fluid which I already told you. Preoperatively 2 ml per kg per hour. With the fluid we have to replace. So 50 kg person. Then third space losses depending on the incision and the type of area of this one, they are replaced with 4 ml, 6 ml and 10 ml losses. So abdominal surgery, severe loss, then 10 ml per kg. So 50 kg person, 500 ml per hour we have to give during the surgical procedure. Blood loss is replaced with colloid of equal volume, blood of equal volume, or crystalloid of 3 times. 50 kg person coming for this one, maintenance fluid is 500 ml first hour, preoperative deficit 500 ml, third space losses 500 ml, 10 ml per kg we have calculated. Second hour 250 ml is the preoperative deficit, remaining things are the same. Third hour also same as second hour. Fourth hour onwards only, no surgery, surgery is over, only maintenance fluid. Post-operatively we have to do 2 ml per kg per hour. So surgeon writes 6 hours of fasting and we have for 6 hours. So 600 ml into 600 ml we have to. Suppose surgeon says that till morning, tomorrow morning, you calculate how many hours till tomorrow 9 o'clock. That is, say 20 hours. So 20 into 100, 2 liters we have to replace. Children we use 4 to 1 farm. First 10 kgs 4 ml, next 10 kgs 2 ml, next 10 kgs more than 20 kgs 1 ml per kg. 23 kgs children, first 10 kgs 10 into 4 40, next 10 kgs 10 into 2 20, next 3 kgs 3 into 1 3 ml, so 63 ml.